welcome everybody. My name is Marc Carrier. I'm one of the hematologists at the Ottawa Hospital. I'm a member of Thrombosis Canada, and I have the great pleasure today to have two of the co-authors from the latest CHEST guidelines and expert panel report on COVID-19. Dr. Philip Wells, he's the Chief and Chair of the Department of Medicine at the Ottawa Hospital, and Dr. Grégoire Le Gal, he's one of the thrombosis specialists at the Ottawa Hospital. Gentlemen, welcome. And we'll take the opportunity of having you guys on the line to ask a few questions about prevention, diagnosis, and treatment of venous thromboembolic disease in patients with COVID-19. And if I may, I'll go directly with Dr. Le Gal, and we'll ask you, what was the overarching objective for the development of this publication, Dr. Le Gal?
Thank you, Mark. Well, as you know, very early after the pandemic started, we've seen a lot of early reports of high rates of thromboembolic complications in patients with COVID-19. And soon after, we've also heard from many countries or institutions that there were concerns about which thromboprophylaxis was to be used in these patients. And some institutions or societies started to put forward some guidance documents or some guidelines with increased dose of low molecular weight heparin at times, or some regimens that would be based on other criteria. So we felt that there was a need for a guidance document that would be based on available evidence, and also on seeing how much we should divert from the existing ACCP guidelines on thromboprophylaxis, or whether they were still okay to use in that specific setting.
Certainly very important, given that we're getting a lot of information, a lot of publications, and clinicians really need guidance in order to make treatment decisions for these patients. So very much appreciated. Dr. Wells, what is the guidance around diagnosis of VTE in COVID-19 patients?
It's an interesting question because we've seen from the literature out there, which, as Dr. Le Gal mentioned, is quite varied, that some studies are finding very low rates of VTE and some are finding extraordinarily high rates. So we wanted to look at the literature to determine what were people doing, what advice can we give for the best way to diagnose patients. And the reality is that the literature is not that useful in this area. So it came down to one of the key points we looked at is whether we should be screening for VTE. And at this point, our recommendation is not to screen for VTE because there's insufficient evidence to support that. But we also felt that it's very important for physicians to have a low threshold for testing. So if patients should clinically deteriorate acutely, not just to assume that this is due to advancement of COVID-19 in that patient, but to strongly consider whether this may be a pulmonary embolism that caused their atrial fibrillation or hypotension or deterioration in oxygenation. So having a low threshold for testing is something that we recommend, but not routine screening. Beyond that, the tests are the usual tests we use, ultrasound for DVT, CT generally for pulmonary embolism. We looked into D-dimer, whether that might be useful, and there are studies that have reported that the D-dimer level does go up as patients have venous thromboembolic events, but there was certainly no consensus or capacity for our group to designate a D-dimer cutoff below which there would be a high negative predictive value. So that's the basic guidance that we've come up with. No screening, test with low suspicion. D-dimer at this point is not that helpful. Use the usual diagnostic tests and usual interpretations.
Thank you for a great summary. It often is quite a clinical conundrum for clinicians when patients are really sick, right? So that'll be important for them, I'm sure. Maybe one of the most important thing is prevention of these venous thromboembolic complications. And Dr. Le Gal, what is the recommended type and dosing for thromboprophylaxis in patients who are hospitalized and acutely ill with COVID-19?
Yeah, you're right. That was likely one of the most challenging questions for our group. Again, in the context of some other groups recommending higher increased dose or intermediate or even full dose anticoagulation for admitted patients with COVID. In reviewing the evidence, we didn't find much to make some recommendations that would be very different from what we had in the last version of the ACCP guidelines. Perhaps the only thing to mention is that in the ACCP guidelines, the first step is to do risk stratification, and the recommendation is to give thromboprophylaxis to acutely ill medical patients, provided that they are deemed at high risk of VTE using one of the validating clinical decision rules, but not to give any thromboprophylaxis to patients at low risk. We had a lot of discussion around that, and the feeling was that COVID patients had many of the predictors for VTE among inpatient, and that it was very we didn't have any data about how the Padua score or other models would perform specifically in COVID patients. So the feeling was that it was reasonable to recommend a broad indication for thromboprophylaxis in COVID patients whenever they are admitted, without having to go through that step of the risk stratification. Okay. But then, so next question was whether to increase the dose or not, and in acutely ill medical patients, but not in the ICU or not intubated, we did not find much evidence to support higher doses at this stage. And in particular, the incidence of VTE in those patients who are not admitted to the ICU did not seem extremely high. And certainly we didn't have any data to support the fact that an intermediate or full dose low molecular weight heparin would be superior to standard doses. So basically, for acutely ill medical patients admitted with COVID to hospitals, the recommendation was to stick to existing standards in terms of thromboprophylaxis.
You mentioned specifically not admitted, or I should say patients not admitted to the intensive care unit or intubated. And I think the reported rates of venous thromboembolic disease in ICU patients might be a little higher. Dr. Wells, did you guys decide to do different recommendations for critically ill patients?
We found similar things as to what Dr. Le Gal just explained, that there really isn't strong evidence in favor of using a higher dose. We certainly recommend that you use low molecular weight heparin as prophylaxis in this patient population. There are a few key points I think that came out of our review. One is we feel that it's low molecular weight heparin over unfractionated heparin for a few reasons. One is that we want to limit healthcare worker exposures. So once daily dosing is probably better than twice daily dosing in terms of that exposure. Well, it is better. The other thing is we felt that we looked at whether DOACs might be indicated, and there really were no studies that had even used DOACs, but based on other factors such as the high risk of sudden deterioration of patients, the higher risk of drug interactions from antiviral drugs, and the higher incidence of acute kidney injury in these critical care patients, that DOACs should not be employed. So as similar to Dr. Le Gal, yes, prophylaxis as per current guidelines for other critically ill patients, low molecular weight heparin, but somewhat different is we recommend that over unfractionated heparin and certainly over fondaparinux, and as I mentioned, over the DOACs at this point.
Thank you very much, Dr. Wells. These are very important pearls that clinicians will use, no doubt. Dr. Le Gal, what is the recommended duration for thromboprophylaxis in hospitalized COVID patients?
That was another matter of debate, and one of the big questions was whether these patients, when they go back home, should they continue to be on thromboprophylaxis or not. And so one of the reasons for that would be that they could still be inflamed and could still be relatively less mobile given the fatigue associated with the disease, and given that most of them will have to continue to self-isolate at home when they go back. But in reviewing existing data at the time we were writing the guidelines, we really could not find any data about what would be the incidence of VTE following hospital discharge after an admission for COVID. So we decided again not to change existing guidelines and to remain off extended thromboprophylaxis, at least for the time being, pending ongoing investigation about what would be the risk of post-discharge VTE after an admission for COVID.
Thank you very much, Dr. Le Gal. And finally, another important clinical question would be what to do when patients are already on blood thinners for, let's say, a previous venous thromboembolic disease and they're admitted to hospital with COVID-19. What should clinicians do about their anticoagulants? Dr. Wells, what do you think? What advice would you provide them with?
We suggest that in this situation, you change the patient over to low molecular weight heparin. It's generally, most of these patients will be in a prophylaxis setting anyway, unless their VTE has been, within the previous month, they're going to be in that long-term phase or extended phase of prophylaxis. And in that situation, there's plenty of evidence that low molecular weight heparin is effective. And we get around the issues that I mentioned earlier about potential for rapid deterioration, the potential for renal dysfunction, the potential for drug-drug interactions. So in general, the recommendation would be to switch to low molecular weight heparin prophylaxis. It's obviously a little less clear if the patient's on the DOAC for atrial fibrillation, and that's a more difficult thing to address. I think that's probably a day-to-day decision that you would take in that patient.
Right. Well, thank you very much, Dr. Wells, Dr. Le Gal. Thank you so much for taking a few minutes out of your busy schedule to provide some insights on the prevention, diagnosis, and treatment of venous thromboembolism in patients with COVID-19. For the listeners, please have a look at the CHEST guidelines, the ACCP guidelines, and expert panel report that was recently published in CHEST. Thank you very much, gentlemen.